for me to be bestowed upon this important responsibility of hosting the important event of IAGS. IAGS is taking strides in various academic programs. It yet another initiative on bringing the legends to you so that you proceed with legendary thoughts towards a legendary life. This is the idea of having this program. So we are poised to hear two important senior most surgical fraternity and endoscopic fraternity of this part of the country and our neighboring friendly country, Japan. For that, we have met today at this evening important time. So I'm happy to host this important program, IAGS Prime Time. May I request our president, Dr. Raman Goyal, to formally inaugurate the program.
Good evening, friends. It's really a proud moment because IAGS is starting another major activity. And this is not actually a webinar. That's why we are calling it a IAGS Prime Time. This particular activity is being brought specifically to ensure that we hear from the seniors, and this has got two components. So in the first half, we will have a master who has pioneered a technique, and we are looking forward to see not the technique alone, but we are looking to hear his experience of hundreds and thousands of procedures that he has done, because that is what matters more once you have learned the basics of a technique. So I'm honored that Professor Inoue from Japan has joined us, and especially because it's a very odd hour for him. It's morning in Japan, and he has agreed to be a part of this activity. So IAGS is really obliged for his presence. In the second half of the meeting, we have our founder president, Professor Udwadia, who is sharing his moments, the critical moments in his life, how he thought surgical practice should evolve. And this component will always have a legend who will be talking about how they changed, how they shaped surgical practice in their own countries, in the region, and across the world. And this is a matter of personal pride for me that I got an opportunity to interview him. I have been in surgical practice for 33 years. I've been in Mumbai for 30 years. But those 40 minutes that I spent with Professor Udwadia have proven to be a turning point in my life, because they have defined how things should go ahead in next 10, 20, 30 years that I practice surgery, COVID permitting. So I'm very happy that Dr. Kanagvel, who gave this idea of IAGS Prime to us, and we readily accepted that, is ultimately coming to fruition. And we will have this fortnightly event where each time we'll be bringing the legends in surgery to you. So I'm very happy to inaugurate it on behalf of the executive committee of IAGS today. And I hand it over to Dr. Kanagvel to take charge and to start the academic activity today. Thank you so much.
Thank you, sir. It's indeed a privilege for me, bestowed upon by the IAGS and the executive committee. I thank the executive committee and the president for having trust on me, and I'm indeed pride to having take a lot of pride and stride to introduce Professor Inoue. I would like to put on official record that the Heller's myotomy was first mentioned or first published as early as 1913. Almost it stood strong for close to 100 years or close to a century. And it was Professor Inoue who strongly believed a surgery can be avoided for treating achalasia of the cardia. Professor Inoue has been trained at the most important centers in Japan, and he has been associated with a single institution for the past 4 decades, and is currently the president of the Japanese Gastrointestinal Endoscopy Society. In fact, Professor Inoue has now moved on from teaching the techniques of achalasia poem procedure to looking upon the lacunae of the poem procedure. In fact, he has very recently published the issues of reflex and how to do an endoscopic anti-reflex procedure along with poem procedure. And then he also has innovated third space endoscopy into the chest. And to his hands, he also has published a large series, multi-center series for rectifying patients who have recurrence after laparoscopic Heller's myotomy, and a huge combination of thousands of permutations and combinations of troubled achalasia patients have been relieved by his standardization of technique. In fact, he regularly conducts the courses for the American Society of Gastrointestinal Endoscopy, the Middle East surgeons, and he always has a handful of fellows who work with him for a period of 1 or 2 years to learn this procedure, and they go on to propagate the technique of poem. In fact, the IAGS is very honored to have the presence of Professor Haruhiro Inoue amidst us, and we are waiting to listen to your wisdom, sir. Over to Professor Inoue.
Hello, can you hear me?
Very well, sir.
So good evening, all the Indian colleagues, and thank you very much for your kind introduction for me. And I also appreciate the Dr. Lam and Go for your kind invitation to this important workshop. So I would like to share my slides. Okay. 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 So this is my COI, and we published our procedure Journal of Endoscopy in 2010, 10 years ago. The procedure itself like this. So create a submucosal tunnel and place the circular myotomy in a submucosal tunnel. So please note the date of the procedure. So 2008, this is the world first case of poem. After submucosal incision, injection, we place a mucosal incision in the anterior wall of the esophagus. So getting in after creating a submucosal working space, now we started circular myotomy in this case. So we have already completed anterior short myotomy in this case. Then we close the mucosal entry using clips. Junction is open like this. So, of course, we selected the mild achalasia patient in the first case. The procedure, this is a volume swallow before and after procedure, very smooth passage of volume. This is a memorable shot at the time of a third case of poem procedure. So anyway, the first case, the symptom, this is the Eckart score improved very well. And the I met with this patient 8 years after procedure. So he is totally fine and he can eat well. And the patient satisfaction is 100%, no GERD symptom. After this procedure, so far we performed more than in our hospital 2,200 cases. We published the data at the time over 500 to American College of Surgeons. So first, I'd like mention about the myotomy rings. For type 1 achalasia, classical achalasia, we can place the short myotomy. Short myotomy, the 5 to 7 centimeter myotomy, that is the very similar to surgical myotomy. Yes, like this. In the case of a vigorous achalasia, we have to place a longer myotomy. So in the point procedure, proximal extension of the myotomy area is very easy. So we can place the long myotomy. So this is a myotomy rings based upon the Chicago classification, but it looks a little bit complicated. Then from the treatment point of view, we can summarize 3 categories. So in the Chicago type 1, type 2, we can place a LES myotomy. And for vigorous achalasia, Chicago type 3, so we place a body plus LES myotomy. In the case of a diffuse spasm and jacama esophagus, we place the selected myotomy to esophageal body. So LES preserved. So Dr. Caridas and Dr. Pandolfino from Chicago, they reported the usefulness of the poem particularly to Chicago classification type 3. Of course, we can apply poem to type 1, type 2, and the outflow obstruction. Poem can be applied to spastic motility disorders very well. Some reports demonstrate very good results. This is a case of a diffuse esophageal spasm. So before procedure, left side, you can see it's a very strong spastic contraction. And then after poem procedure, we place a long myotomy and the volume goes very smoothly. So in this case, we can confirm the normal LES function. So in this case, we preserve the lower esophageal sphincter. So this is the endoscopic view of this case. Before procedure, we can recognize the lots of abnormal contractions, esophageal body, and the right side, you can see a diverticum. Anyway, so in this case, in a posterior wall, we place the submucosal tunnel, and now we perform the double scope check. Anyway, so we place the circular myotomy. In this, like this, the diffuse spasm or jacama patients, mostly the muscle layer is usually very thick. Then we place, this is the distal end of the submucosal tunnel. You can see a thin muscle layer. That is a lower esophageal sphincter muscle. Then we preserve the this one. This is the starting point of the lower esophageal sphincter. Then we preserve this LES. Okay, the proximal part has thick muscle area has already been dissected. Okay. So in this case, symptom score improvement is dramatically well, 9 to 0. Recent publications of the poem procedure, so like this, any institution, the success rate is very high, 92 to 100% success rate. But potential problem of the poem is the postponed GERD, 20 to 50%. So how to avoid the postponed GERD? That is the very, very important issue for us. So simple method, we recommend double scope method at the time of the procedure. control the gastric myotomy length to 2 centimeter. We insert the 2 scopes. So procedure is like this. This procedure was first reported from Portuguese doctors. And then the mother scope in the submucosal layer and the submucosal tunnel, and the another monitor scope is inserted in the stomach. And then, so like this, we can confirm the light passing through the mucosal layer in the gastric cavity. So we can control the gastric myotomy rings less than 2 centimeter. So this was already published in a guideline. You can read it. So one of the LCT reported gastric myotomy length is more than 3 centimeter. It causes the severe reflux esophagitis after POEM procedure, potentially. So it's better to control the gastric myotomy length less than 2 centimeter. So another technique is a POEM plus fundoplication. So this is the recreate of the Helado procedure, surgery, endoscopically. Dr. Akiko Toshimori. So she supported this procedure very well, one of my colleagues. Anyway, so this is the first case of a POEM plus fundoplication. This was 3 years ago. So far, we performed this procedure in 43 cases. Okay, so this is the actual procedure. We place the anterior myotomy, and then after completion of a POEM procedure, at the distal end of the submucosal tunnel, we cut the peritoneum and get in the abdominal cavity, and we place the distal anchor and the proximal anchor, and then after that we pull the gastric fundus to the place of the abdominal esophagus. We performed a live demonstration of this procedure in the at the time of ESGE days last year in Prague. So this is the demonstration at the venue, and you can see a fundoplication already done. We utilize the endoscopic hand suturing device for this procedure. VLOC, that everybody knows well, and this is a hand suturing device. And I like this. After getting the abdominal cavity, we place the distal anchor on the anterior wall of the stomach. And then distal end, we place a prejet. And then we place a proximal anchoring like this, and normally place 2 stitches. So action procedure. This is the submucosal tunnel, and then we cut the peritoneum. So behind you can see a back side of the left liver lobe. Once again, this is very important. So cut the peritoneum, and then we open the peritoneum window. Of course, we insufflate the CO2 through the endoscope, and then get in abdominal cavity. The top is the back side of the abdominal wall, and the bottom is the anterior wall of the stomach. And we place the stitch like this. So this is a intragastric monitoring. Needle is coming in the stomach, in the out. Also, we can recognize open hiatus. So, okay. This is a proximal placement of the second stitch, like this. Okay. Needle is coming. And then you can see in the gastric scope, we can recognize a very nice fundoplication. So this fundoplication, endoscopy image of the fundoplication, this image is very similar to after DOE fundoplication. So this is the clinical results in 43 cases. Technically, we completed this procedure 100%. This is a 24-hour pH. Yes, so Domista composite score in the control group, POEM alone is like this, and in the case of a POEM plus fundoplication group, composite score improved, statistically difference. Now we think like this. So, of course, the Nissan fundoplication is a strongest fundoplication. Anti-reflux effect is very strong, and the toupee and the DOE is a mild, very mild, and the POEMF is a very similar to DOE. And the another procedure is AMA, but today we have no time to talk about the AMA procedure. So our treatment strategy for achalasia is like this. In the case of achalasia, we perform the regular POEM procedure, POEM alone, and then posterior myotomy. We standardly do it, and is very, very rare, but less than 1%. Some patient becomes a refractory GERD. Then we place a peroral endoscopic fundoplication in the anterior wall. It's a DOE fundoplication. Okay. So thank you very much for your kind attention. Thank you.
Thank you, Professor Inoue. In fact, I believe we gave a very short time for you to give your important outcomes of the lifetime perfection of a specific technique. We have few questions from the floor, Professor Inoue. Can I ask you those questions?
Yes, of course.
Yes.
Welcome.
Professor Inoue, you've been doing this procedure for more than 2 decades now, this POEM procedure.
Mm-hmm.
Like, how long is your longest follow-up after POEM procedure? And do you find the outcome any different from a laparoscopic procedure?
So, after introduction of the POEM procedure, we have only one Herado procedure. Honestly, last 12 years. First case was 2008. After that, so all the cases in our hospital except one case, we did the POEM. So we didn't perform we have never performed the RCT in the POEM versus the Herado procedure. But our results of the POEM not bad. The only potential problem is the postponed GERD. Honestly, as I mentioned, and our data demonstrate, we don't have very not so many severe GERD patients. Among 2,000 patients, only 2 cases received the anti-reflux procedure, anti-reflux surgery. So 0.1% of the POEM patient receives the anti-reflux procedure. So that is the negative factor of the POEM procedure. Very small percentage patient, but becomes a severe reflux. On the positive point of view, POEM, that is a major advantage for vigorous achalasia or other motility disorders of the esophageal body, particularly diffuse spasm and the jackhammer, nutcracker esophagus like that. So I think POEM is well accepted procedure to all the surgeons as well. Same to our gastroenterologist.
Thank you, Professor Inoue. The next question is, Professor Inoue, you have been doing myotomy for achalasia procedure. In bariatric procedure, especially when there is sleeve fibrosis or a pouch fibrosis, can your procedure be of use to handle these problems? Do you have any experience in dealing with this?
Yeah, once again, so your question is are scar formation after this procedure?
Yes, actually, after sleeve procedure for a bariatric surgery, if there is a stenosis of the remnant stomach, especially when I believe the surgeon is made a very narrow sleeve. So patient is having dysphagia post sleeve gastrectomy. So he would like to know, before going for a laparoscopic revision, can this POEM procedure be extended towards the length of the entire stomach, so that gives relief to the patient's dysphagia post sleeve gastrectomy procedure?
I'm sorry, I can follow your question. So once again, so
Professor Inoue,
I know the sleeve.
Professor Inoue, Dr. Raman Gol is a very senior bariatric surgeon. I will ask him to phrase the question for you. Dr. Raman, please.
Yeah. No, so Professor, this is not about the POEM for achalasia. What Dr. Kanagvel is asking is that if after a sleeve gastrectomy in bariatric, if there is a suture, can that be relieved? A submucous dissection myotomy can be done endoscopically for stomach strictures.
Okay. Now I understand your question. So application of the submucosal myotomy to the stenosis after sleeve gastrectomy, you mean?
Yes.
So I think theoretically, yes, we can apply, but I myself am not. I never performed the sleeve gastrectomy.
Yeah.
So because in Japan, of course, we don't have not so many obese patients in Japan. Anyway, so I'm surgeon. I'm a esophageal surgeon, but I myself don't perform the sleeve gastrectomy. So I have no experience myself, so I cannot answer it.
Thank you, Professor Inoue. The next question from one of the surgeons is, would you like to share your insights and experience in use of POEM procedure in pediatric achalasia?
So it's a very, very good question. Very, very important question. So our youngest patient is a 3-year-old. 3-year-old. And the pediatric patient age of less than 15-year-old, we have roughly 30 cases. We did it, and we complete the procedure, and the result is not bad. But so we have to be very careful. So young pediatric achalasia patients, some of them is at congenital stenosis of the esophagus. So we have 6 cases so far among 2,000. So their characteristic that looks very similar to achalasia, but they have so congenital achalasia, congenital stenosis of the esophagus. So in such a case, so performing the POEM procedure is very difficult. We can do it, but not easy, like in a submucosal space, we can see a lot of severe fibrosis. So it's very difficult to dissect in a submucosal space. Anyway, in such a case, we try to perform the POEM procedure, but it's a very technically demanding. So please let you know, in some pediatric patients, they have the disease of the congenital stenosis, not achalasia. But so in the case of achalasia patients, so we can apply POEM anyway.
Thank you, Professor Inoue. There is yet another question. A patient who has the laparoscopic hairless cardiomyotomy, who possibly had a type of underapplication, but he has not mentioned. But he says post-myotomy, after a year-long treatment with proton pump inhibitor and prokinetics, patient continues to have severe reflux. Do you have any experience in performing the POEM-assisted fundoplication in these type of post-laparoscopic patients coming with reflux, symptomatic reflux?
So, okay. So your question is the application of the POEM-like submucosal approach, and then make a fundoplication in the case of a post-Heladol.
Yes.
Post-Heladol GERD.
Yes.
So post-Heladol GERD. It's a very difficult to. It's a very important. But post-POEM failure of Heladol is a very good candidate for POEM. But the post-Heladol GERD, it's a very difficult to control it. So of course, post-Heladol patient. That means the patient had the achalasia. So esophageal clearance is a nil, and also severe reflux. So it's a very difficult to manage it. In the case of course, a PPI or PCAB is a best treatment for them. But if it's not enough to control the reflux, at the time is I'm not sure about the at the time. So one of the choices is sphancectomy. We cannot control it. So, for example, if we apply the anti-reflux mucosal ablation in such a case, but some patients recur the symptom of the stenosis, so another problem. So it's very difficult to handle it. Question is very important. Good question, but the answer is very difficult.
Thank you, Professor Inoue. The last question for you for this evening. Professor Inoue, now we are using POEM procedure for proximal achalasias as well. We are using POEM procedure for handling esophageal diverticula. We have extended myotomy for gastric POEM. Like the learning curve, is it mandatory for the newer procedures also, or one is proficient or doing a POEM for achalasia can attempt to do the next level of procedures? Please guide us.
So POEM. So today the all of you are laparoscopic surgeon. And among the endoscopic procedures, compared to endoscopic submucosal dissection, ESD POEM procedure is technically easy. And if you are a surgeon, I myself is esophageal surgeon, I perform esophagectomy and the misemphantification, some other the gastric surgery as well, laparoscopic, total gastrectomy, everything we do. I myself do it. So like us surgeon, we know the anatomy very well. So we can perform the POEM procedure. Endoscopic handling technique is not so difficult, I think. And the POEM is the first step. And the second step is G-POEM, gastric POEM for gastric paralysis. Is technically is the same. Technically same, not so difficult like ESD in the duodenum and the colon. It's a very technically demanding, but the POEM and the G-POEM is not so difficult, I think. If you are a good flexible endoscopic surgeon. Yeah.
Thank you, Professor Inoue. One of our past presidents, Professor Abhay Dalvi, has asked a question. Sir, you have devised guidelines for the learning curve of POEM procedure. How many procedures a surgeon have to minimum do it before technically becoming independent to do a POEM procedure?
So it's also a good question. So of course, everybody performs surgical procedures usually. But it depends on the doctor. He or she is how much procedures using a flexible endoscopy. If the surgeon performs the flexible endoscopy, or upper GI endoscopy, colonoscopy, and the routinely, you are very familiar with handling the flexible endoscope. So POEM procedure is not difficult, I think. So, but if you are so far in your career, you just perform the laparoscopic and trachoscopic surgery alone, without using the flexible endoscope, no carrier over flexible endoscopic surgery. So it's technically a little bit difficult. Anyway, learning curve is 30 cases, I think. So it's the same to any other surgical procedure. So 30 cases, we have some level of surgical step, technical step, going up to the level plateau.
Thank you, Professor. Last question is, Professor, the POEM has taken away the laparoscopic hairless procedure from the surgeon to the endoscopist. Your innovation of POEM F, the POEM assisted fundoplication, do you think that will also be taken away from the surgeon to the endoscopist?
Yeah. So I think that it's a very important point. So I think some surgical procedure can be done by flexible endoscope. So it's so if laparoscopic surgery is a minimally invasive surgery, I think so this flexible endoscopic intraluminal approach is it's a notes procedure. So natural orifice transluminal endoscopic surgery. So this is a least invasive procedure, I think. But it depends. So myotomy and the dome fundification, it's a relatively simple surgical procedure. So we can do it using flexible endoscope, I think. But so other procedures is at this moment is I think laparoscopic approach is much better.
Thank you, Professor Inoue, for staying so late in the night. It is close to 1:30 a.m. in Japan. Thank you so much. And the questions are going to be endless because our surgeons are very, very happy to have you and listen to you. We would like you to invite for a longer talk at a later point of time with the president's permission. We are very much honored to have you listen to your talk and taking all the questions even at the very late hour in Japan. Thank you, Professor Inoue. I now request our president, Dr. Raman Goyal, to formally thank you.
Thank you very much. It's my honor.
That was a wonderful talk, enlightening. And we have a lot of surgeons in India who do flexible endoscopies. So I'm sure, they will be happy to take it up. And many of them are actually started doing poem. So I'm sure this will be interesting, and we'll invite you to demonstrate a poem with fundoplication, door fundoplication at one of our conferences. Thank you so much. Good night.
Thank you. Thank you very much.
Okay.
Have a good evening.
Thank you, Professor Inoue. Thank you. Please sign off.
Bye.
It is very late. Thank you for staying with us. Please feel free to sign off.
Thank you.
Thank you. Now, we move on to the next important agenda for the evening. In fact, legends are not made overnight. It is the legendary effort of their lifetime which makes them legendary. To be accepted as a legend by the society is not an easy task, or you cannot enforce the society to call us a legend. It is consistent effort with absolute clarity of vision. One need to work from the beginning part of their career to be called as a legend. Now, in fact, the ultimate pride and pleasure for me is to introduce Professor Tehemten Irak Udwadia. In fact, most of us revere him as a godly figure who has brought in the science of laparoscopic surgery to India. Most of the important newer technological innovation is quite costly, not reachable, and very few surgeons end up doing it. But Professor Udwadia brought in the technology of laparoscopy into the country, into a government teaching hospital, and later ensured the technique and the technology of laparoscopy reaches the surgeon who works at the most remote part of the country, and he made the platform very strong for the surgeons to migrate from basic laparoscopy to advanced laparoscopy at various levels possible. In fact, we never had a second choice to have a legend to talk to us. And in fact, when we requested, Professor Udwadia was very kind enough and he immediately agreed. And more so, I think this is one of the first, or I think it is the first physical interaction which Professor Udwadia has had during this COVID era. And it is none other than our president, Dr. Raman Goyal, took the privilege to interview Professor Udwadia sir. And in fact, many life-changing answers have been given by Udwadia. Let us all listen to his wisdom. Nitin, can we have the video on?
And then you realize that the person whom you are interviewing today has reached to such great heights that you feel so small on one side, and you look up at him and see what is possible or what is feasible. I am absolutely honored to be in company of a person who as a surgeon has achieved practically everything in his lifetime. When I say everything, it means training, professional honors, and civilian honors. I mean to say, a gentleman who has been trained in India, who went to UK to do his fellowship, FRCS in Royal College of Edinburgh and Royal College of England, who came back to India and started teaching surgeons in India in Medical College, Grand Medical College in Mumbai, who was subsequently honored by the highest medical award in India, the B.C. Roy Award. And then he got Padam Shri in 2006 and subsequently honored by Padam Bhushan in 2017. Not only that, he was also been honored by OBE, Order of British Empire, by Queen Elizabeth II. I think it's probably he's now probably the only surgeon from India who has got so many awards and recognition for his work. And obviously, I'm sure you have guessed it right. I'm talking of Professor Tempton Eric Udwadia, who is also the founder president of IAGS, the Indian Association of Gastrointestinal Endosurgeons. Professor Udwadia has been honored by so many associations that it's impossible to list all those honors in next 30 to 40 minutes of the interview time that I've been given. He had been president of ELSA, the Society of Endoscopic and Laparoscopic Surgeons of Asia. He has been president of International Federation of Societies, Endoscopic Societies, IFSIS, in past, and has been honored with fellowship of American College of Surgeons. So it's an absolute pleasure and honor to interview him today. As I took over IAGS, I thought is the time to make sure that we know his thoughts, his ideas, and his vision, and we maintain it for our record of IAGS. Deeply honored to have Professor Udwadia with us today, and I would like to hear your thoughts, sir. And I'm so honored that you agreed to meet us during this COVID pandemic time for a one-to-one interview.
Raman, I can assure you the honor is mine. I can also assure you that all the things you said are perhaps inflated, and I'm basically just an average run-of-the-mill surgeon. Like all other surgeons in India, I have no special qualifications, and I am happy to be just one of Indian surgeons.
So, sir, to start with, when I was going through your biodata, I realized that you have been trained as a surgeon in India, then you did your training in UK, and then you came back and trained so many thousands of surgeons in India. How do you see difference in training, surgical training in India and UK, and how that can be improved if there are any lacunas in India?
I was very fortunate in my training in India because I worked with Professor Sen, and I was his thoracic surgery registrar and his general surgery registrar, and he had a dog lab where I was the ICMR fellow for several years. So with the training I had in India was a very thorough training. And when I went to England, I felt confident that all I needed to do was to just pass my exam, and if I got a job, I would do it as well as any other British surgeon. I was very lucky to get a job because in the early 60s, they were not giving jobs freely in England. And somehow, thanks to Professor Sen's contacts, I managed to become a registrar to a teaching hospital in Liverpool, Royal Liverpool, without even applying for the job. And I found that there was a definite difference in the treatment. The training in England in terms of patient care was far more meticulous for the simple reason that the volume of patients in India is so vast that the houseman is literally overloaded with work and has no time for niceties. He has no time for research, he has no time for reading. Whereas there, there was ample time because the national health was relaxed and they took a certain number of patients, certain number of operations, and everything else was on the waiting list. Whereas India, we tried to keep the waiting list as low as possible because the patient was off work and needed to work. And I would say that for a surgeon, primary training should always be in India because the volume of work, the amount of practice he gets, the experience he gets, he will never get in any other part of the world. And if he's fortunate to have a good training center like the KEM or any good training center, there's nothing better for surgical education than to work in India.
People think that when you have achieved so much in life, you have been a successful person, but I'm sure you have also gone through your period of struggle. So what is your thoughts about how can you advise those who are struggling surgeons, young surgeons today, and what is the role of working in a teaching institution on evolution of a person as a surgeon?
I returned from England in 1963, and my only attachment was to the JJ Hospital as an honorary assistant professor, to the Wadia Children's Hospital as an honorary assistant pediatric surgeon, and to the KM Hospital as a surgical research fellow. In other words, I had only free hospitals attachments, I had no private hospital attachment. So my work in terms of earning was very poor. I used to sit in my consulting rooms, and for the first 2 years, all I would do was read surgery, write articles, write review papers, and the sort. The next 1 year, I was so fed up that I stopped reading surgery and started reading books like Oscar Wilde and Shakespeare and other books. And in the fourth year, I was so fed up that I wouldn't read anything at all. It took a long time for me to get an attachment to the Pasteur General Hospital, the Breach Candy Hospital, and it was only in 1967 that I really started earning money. During that period, I was severely frustrated in terms of income, but I was so greatly satisfied by the volume of work I was doing at the JJ Hospital, at the Pasteur General, at the Wadia Children's Hospital, and in the dog lab at the KEM, where we had started the heart transplant program, that surgically I was fully satisfied. I think the important thing to do when you come back is to make sure that you are attached to someone or some unit which can give you surgical satisfaction. If you have surgical satisfaction, it is not important to have monetary satisfaction because you will always have enough to put food on the table and have a roof over your head. And gradually you will be surprised that if you resist the temptation of cutting corners, if you resist the temptation of split practice, if you resist the temptation of running down your colleagues, then ultimately you get a practice which is based on patients. Your patients start sending you patients. And that is a practice which snowballs. It just goes on increasing in volume even till today. And that is a practice no GP can ever take away from you. So I would request that you stand firm to your convictions and you are bound to make good because your work will speak for itself. And whilst you're waiting and in the process of frustration, try and get doing surgery with someone, assisting surgery, going for free assistance, whatever it is, asking for an attachment, honorary attachment to any hospital, even if it's not a teaching hospital. And I can tell you that the ultimate way to grow in surgery is to be in a teaching hospital. Because in a teaching hospital, you don't teach. In a teaching hospital, you learn. And the amount of learning you get in a teaching hospital is amazing. Your residents are teaching you, your students are teaching you, your patients are teaching you. And in India, the volume of work, I mean, we had 20 allotted beds at JJ Hospital in my unit. It was a tertiary care hepatobiliary unit, and at any one time we had over 80 patients in the ward, on the floor, between the beds, under the beds. So teaching hospital, at that time at least, was a unique experience for any surgeon.
So sometime in your career, sir, you thought of laparoscopy as a game changer. Or did you think about it as a game changer, or did you think just as an addition to your general surgical practice? So what made you think of laparoscopy as an addition to open surgical work?
You see, at JJ Hospital, as I told you, we had about 80 patients at any time. And the infrastructure was so poor that a barium meal would take 3 weeks to materialize. And the waiting period was so long that it was causing the backlog. I was lucky to see a gynecologist doing a diagnostic laparoscopy, gynec laparoscopy, and I requested if I could look into the telescope, and Dr. Motasha was doing it, and I raised the head end of the bed, reversed, and I was amazed at the clarity, the clear vision I could get. And then I realized that if I had a laparoscope, our diagnosis of patients would improve so fast that we could have a rapid turnover and make a very efficient ward. And that is why we went to, at that time, medical instruments had a duty of 360% import duty. Hence, I went to Germany, got the laparoscopic equipment, smuggled it in between the saris of my wife, and came to India. And I had no conscience biting me because I was using it only for poor patients in a teaching hospital. And the rapidity with which we could have a transformation in the bed turnover was amazing. And we had a tertiary hepatobiliary unit, and we could do full justice to all the patients that were referred to us. That is how laparoscopy came into India, not as a tribute to Western technology, but to have early diagnosis in poor patients in a teaching hospital.
So from the diagnostic laparoscopy, did you ever visualize that we will be going in such advanced laparoscopic surgeries now, the oncological surgeries, bariatric surgeries? Did you ever thought of it at that time?
You see, in 1972 and all through 70s, we were just so happy doing diagnostic laparoscopy, and we used to go to rural India where they had no ultrasound, no investigative. And the surgeons in rural India already had laparoscopes because they were doing sterilization. So they took up diagnostic laparoscopy in rural areas very rapidly. And then we realized that there could be a future for laparoscopic surgery. And when the initial laparoscopic cholecystectomy was described, we immediately felt that with over 3,000 diagnostic laparoscopy behind us, we were in a position to move into laparoscopic operative surgery. We got the equipment in March. My team at JJ and I worked with it for 6 weeks on a trainer I made out of a plastic box. And we were happy to do the first laparoscopic appendectomy, laparoscopic cholecystectomy in the developing world. And people do need the credit for doing the first laparoscopic cholecystectomy. But let me make it very strong and clear that the credit goes to the whole team, the whole surgical unit of about 19 days, the residents, the interns, the nurses, and the theatre nurses and anesthetists of the hospital.
Here is a person who's the question of work-life balance, work-family balance, and also the fitness of the surgeon. I know that you have been a sportsman throughout your life. So how does a surgeon keep himself fit? How much time should he give to his family? How does he give that time to the family, and how much time to work? Because this is very commonly discussed issues now, that how to maintain a work, family, and life balance.
True. This is one of the greatest problems in the personal life of every surgeon. because a surgeon basically has an ego, has a trust to move forward. That's the makeup of any surgeon. And this trust often makes sure that his family is neglected. I am guilty of that because very often I would leave the house before the children woke up and I'd come back after they'd gone to sleep. And that is not the way of good parenting. Fortunately, I have a wife who made up for my absence and did the work of two parents and brought up the children happily. But I am remiss in that I was negligent in the family issue. However, every Saturday, Sunday, I would make sure I had time for the family. We'd go out for picnics, even if it was to Hanging Gun or to Jew. Every Saturday, Sunday, I'd make family time. In terms of fitness, I think if you've been a sportsman from your school days, you have the inborn desire to remain fit. I have a small gym at my house with a treadmill, few weights, elastic bands, which I needed for my physiotherapy after my shoulder replacement. And I try and keep fit. I used to play squash up till I was 35. Then I had a knee problem, so I switched over to golf. And for the last 50 years, I play golf as often as I can. There is a saying that if golf interferes with work, give up work. But we can't often do that. But I can happily say that this weekend, I'm starting golf after 4 months. So some form of activity and some form of exchange, physical exchange, is an essential part of growing up happily. And my golf distance has not decreased over years. At the last All India medical golf tournament, I got the second prize for the longest drive.
In this materialistic world, a lot of frustration comes from expectations. We are, as doctors and as surgeons especially, we are in a great hurry to be at par with a software engineer, or we want to be at par with other specialists who are doing better than us. So what is the role of competition between specialties or within the specialty itself? Should a surgeon compare himself with other successful surgeons, or should we learn to live within ourselves, within our own resources?
Well, complications is an essential part of surgery. A surgeon who has no complications is not operating. Any surgeon who operates and has a volume of work has to have complications. And the important thing is to learn from your complications and make sure that you don't repeat them. The important thing about the complication is to take total responsibility for the complication. The buck has to stop with the surgeon. You don't blame the anesthetist, you don't blame the nurse, you don't blame the instrument, you don't blame the assistant, you don't blame the cautery machine. The buck has to, and when you take the responsibility, two things happen. One, you will make sure that you don't make the same complication again, because you analyze it and analyze it and analyze it, and you tell people, I make this complication. Don't hide it, don't put it under the carpet. And the second thing, if you take the buck for the complication, is you will get the total loyalty of your team. They will say that my boss takes the blame and I give him total loyalty. So it's good to learn from your complications. One of the worst complications, obviously, is death. There is no surgeon that I know of who has not had a death during their experience. And believe me, there are two people who suffer in a patient's death, almost as severely. The patient who has died and the surgeon. The trauma a surgeon undergoes when a patient dies, only the surgeon knows. He has to live with it and he has to overcome it. And it is a terrible moment. And this is why I think surgery is one of the supreme branches of medicine. It teaches you to give life, but it also traumatizes you when 1 in a million death occur. So you have to take your complications and learn from them. In terms of comparing to others, I think there's an old saying, comparisons are odious. You don't ever try to compare. No two human beings are the same, no two patients are the same, no two surgeons are the same. You see, today, people are a little, it's like a little Bollywood, where some surgeons say that I'm so fast, I do a hernia in 14 minutes. Speed is never an aim in surgery. Precision is the aim in surgery. Some people are born fast, they do fast surgery, that's an attribute God has given them. But for everybody to try and be fast for the sake of being fast is not right. Same way, you don't compare yourself. You see, some surgeons do one procedure very well, some do another procedure very well. For example, I would take great pride in my hernia because I was trained ultimately from the top authority in that, or in perhaps hepatobiliary surgeon, because I was for 30 years charge of hepatobiliary unit at the JJ. But that is not, you don't compare. What you do is do what you think is best that you can do. You set your own goal, you set your own level of competence, you set your own aim and follow that. And your aim should be high, so that you go on improving, increasing, and doing better and better work. But comparing, I don't think has sense. Some surgeons might make much more money, you don't want to compare with that. Some surgeons may have far more patients, you don't want to compare with that. Some patients may be very friendly with the other specialties, you don't want to compare with that. You lead your life yourself. Each life is a life into itself, and your family, your surgery, your patients, all ultimately make for happiness. Ultimate aim of life is only one, to be happy in your family, in your work, and in your life. If you're happy with yourself, you're doing a good job.
I don't know about you, but what I have heard in last 40 minutes is like having life mantra. To be happy with yourself, to be happy to enjoy a surgery is what is success. I think in last 40-45 minutes, Professor Udwadia has given the gist of a surgeon's successful life. I don't know whether this is ever taught in a medical school. We acquire it as we age. But when you hear a person who has been there, done that, it reinforces your confidence and it gives direction where we should be headed. I believe this interaction will be remembered by me for sure forever. And this should be of help to each one of you sitting at home, listening to this interview. Please save it, because these kind of pearls of wisdom don't come easily. Professor Udwadia is one of those surgeons who have evolved from a humble background to reach a pinnacle of surgery and still retain modesty to call himself a general surgeon. So I think I wish to thank you, sir.
Thank you
for giving this time. And we are so happy to have you as our patron, mentor. We look forward to you. And I always say this, that people look at blessings from their seniors, but the seniors should know that your health and your well-being is because so many of us, the youngsters, not so young, but I am, bless you with more happiness and health for a long time.
Thank you.
It was mind-blowing wisdom. Thank you, Udvadia sir, for continuing to guide us through. Thank you, Raman sir, for bringing out the best of wisdom from Professor Udvadia. In fact, Udvadia sir had a longer talk with us. The entire talk will be uploaded shortly to the IAGS YouTube channel. We have many other aspects being discussed by Dr. Udvadia. Please feel free to visit the IAGS official YouTube channel to watch the unedited version of Professor Udvadia's wisdom. Friends, today is our first step towards this important agenda of listening to the legends, legendary surgeons who have made legendary skills possible to the humanity. I once again thank the opportunity given by the IAGS leadership, Professor Raman sir, for hosting this unique program. And I am to inform this program will happen every fortnight. We will have two legends speaking to us, one on social parameters, the other on important surgical technique. Please stay tuned to us. We'll be sharing the information about the next program. The next program will happen on 13th September, the second Sunday of September, same time, 9 to 10. Allow us to settle down. We would like to finish the program in 1 hour, but then give us a couple of weeks, couple of programs so that we technically fit into the program. Please share your thoughts. Please share your comments so that we can improve from this on. Thank you, IAGS. Thank you, the surgical fraternity. Thank you, the medical fraternity, for staying back with us to this important event. I look forward to see you all again at another edition. Thank you, one and all. Good night to you.